Okay, corneal infiltrates overview. Description. Corneal infiltrates are focal areas of corneal stromal inflammations composed of accumulations of white blood cells, cellular debris, and protein with associated edema. If persistent, they may lead to stromal tissue loss, keratolysis. Although they may be seen in some non-infectious disease, they are of particular concern because they may be the main presenting sign in microbial keratitis. Infections. Microbial keratitis, where bacteria, virus, fungi, or protozoa have infected the cornea, leads to an inflammatory reaction characterized by corneal infiltrates, usually with an overlying epithelial defect. The inflammation often extends to the anterior chamber, with focal keratic precipitates around the site of keratitis, aqueous cells and flare, and even hypopyon formation and posterior synechiae. Non-infections. A focal steroid inflammatory reactions can occur to either the microbial or non-microbial antigen. They are usually peripheral, less dense, and smaller than infiltrates from infections causes, and the overlying epithelial may be intact. Infiltrates can be associated with soft contact lens wear, especially with poor lens care or extended wear. People with posterior blepharitis can also develop corneal infiltrate adjacent to the lid margin, which is marginal keratitis. Symptom. Secondary to any significant corneal inflammation, the eye becomes red and sore, photophobic, and often the vision is blurred. There is also increased lacrimations. Sign. A discrete opacity is seen usually within the anterior corneal stroma. The center of the infiltrate is often densely opaque and white to gray in color. Surrounding this central dense area, there is often a halo of less intense stromal infiltrations, such that individual inflammatory cells can be seen on slit lamp examinations. There is usually some degree of limbal or conjunctival hyperemia. The lesion should be assessed for the presence of an associated epithelial defect. It may be possible to differentiate between the infectious and sterile infiltrates by their location and size, as well as the presence of associated signs. The company they kept. The pedal mnemonic can be helped in distinguishing the two conditions. An infected ulcer is more likely to be associated with pain, epithelial defect, discharge, anterior chamber reactions, and more central locations. Management. Infections. Microbiological investigation and treatment with the appropriate antimicrobial agents is indicated. Non-infection. If sure that the lesion is non-infectious, then a mild topical steroid QRD will usually lead to rapid resolution of the lesion. This is often covered with a broad-spectrum topical antibiotic QRD. If contact lens are associated, withdrawal of contact lens use and increased lens hygiene are indicated. Changing to disposable soft contact lens may also be indicated. If associated with blepharitis, treatment of the lid disease with lid hygiene and oral tetracycline may be indicated. Review. Usually within 1 to 2 days to ensure resolution and lack of progressions that may indicate an infection. If there is doubt about the diagnosis, the infiltrate should be treated as a microbial keratitis.